good morning to all of you. We are going to commence the 7th scientific session, that is the first scientific session of day 3. We'll be having 7 presentations. Of this, 1 is in non-competitive category. The remaining 6 are competitive category. Every speaker will get 2 questions, which the question answer session will be at the end of the entire presentation. And every speaker gets 8 plus 2, that is total 10 minutes time for the presentation. An alert bell will be pressed for at the end of 8 minutes of your presentation. So we would want the speakers to stick to the time. And the questions, it will be 2 questions per speaker, and no cross questions are allowed. So with that, we'll start the session, although we don't have enough audience, but the show must go on. So with that motto, we'll begin the 7th scientific session on day 3. Yes, can we have the first speaker? So the first speaker of the day is Dr. Preeti Bhutani, and she's going to present on task-oriented circuit class training with motor imagery versus motor imagery for balance and gait rehabilitation in post-stroke patients, a comparative study.
Very good morning to one and all present here. My title is Task-Oriented Circuit Class Training with Motor Imagery versus Motor Imagery for Balance and Gait Rehabilitation in Post-Stroke Patients, a Comparative Study. According to the Global Burden of Disease, global prevalence of stroke in 2019 was 101.5 million people and 6.6 million deaths post-stroke. Kamalakanan et al. In 2017 concluded that crude stroke prevalence in different parts of India ranged from 44.29 to 559 per 10,000 persons during the past 2 decades. Prevalence of balance and gait impairment in post-stroke ranges from 16.7% to as high as 83%. Task-oriented training is a clinical therapeutic approach based on rehabilitation science and is grounded on the principles of motor learning, motor control, and neuroplasticity. Circuit training is a training method that controls the intensity of training systematically and gradually as an intervention to help the repeated training of a large number of tasks. Task-oriented circuit class training, or TOCCT, involves the practice of organizing standing and walking related tasks as a circuit with a series of workstations. Motor imagery is defined as the internal representation of an action without engaging in overt motor output. This is the mental offline rehearsal of action resulting in cortical activation. Imagery training engages the same area of the brain that are activated during exercise, suggesting that activity of imagery muscle is increased. The rationale for the study is, in a study, a randomized controlled trial of motor imagery combined with structured progressive circuit class therapy on gait in stroke survivors done in 2020 by Soni et al. Concluded that SPCCT, when combined with motor imagery, is more beneficial than SPCCT with health education in enhancing temporal spatial gait variables. According to the study, motor imagery in gait and balance rehabilitation for post-stroke hemiparesis in 2017 by Gupta suggested that motor imagery facilitates faster recovery and complements conventional therapy by enhancing walking and balance capabilities of stroke patients. Thus, the aforementioned studies indicate that there is a significant improvement in balance and gait abilities after TOCCT with imagery and motor imagery with standardized rehab norms. The aim of this study is to compare the effect of TOCCT with motor imagery over motor imagery on gait and balance in post-stroke patients. Objective is to find out changes in balance and gait of post-stroke patients. The hypothesis, alternate hypothesis, states there is significant improvement in balance and gait in patients undergoing TOCCT with motor imagery. Alternate hypothesis 2 is there is significant improvement in balance and gait in patients undergoing motor imagery. Whereas a null hypothesis is there is no significant improvement in balance and gait abilities of patients of both the groups. The methodology, the present study is an experimental design. After the baseline assessment, the patients were randomly assigned to group 1 and group 2 on the basis of convenient sampling, 15 participants each. The participants were included on the basis of inclusion criteria, at least 6 months from the onset of stroke to 2 years, age ranging from 30 to 60 years of age, runs from leg 3 to 6, able to walk 10 meters independently with or without any assistive device, MMSE score more than equal to 24, and able to perform motor imagery that was measured through motor imagery questionnaire, revised second version. The score should be greater than equal to 25. Participants with hearing and visual impairment, aphasia, or any other neurological disorder, or medically unstable patients who are excluded from the study. Screening of the patients was initially done, and according to the inclusion criteria, participants were selected and an informed consent was obtained from all the participants in the research. Baseline assessment was done using outcome measures, work balance scale, and Rivermed visual gait assessment. Both the groups received 40 minutes of intervention for 5 days a week for 4 weeks. In group 1, 25 minutes of TOCCT, followed by 15 minutes of motor imagery audio. TOCCT training program was given according to norms, including 10 different workstations, and was intended to improve meaningful tasks related to walking competencies such as stair climbing, balance control while standing and turning. These are the following 10 workstations, starting from sit to stand, standing unsupported on a firm surface, standing with eye closed, standing unsupported with feet together, tandem stand, standing and balancing on Bose wall, walking through obstacles, walking carrying an object, stepping forward and sideways, and stair climbing. The motor imagery audio comprised imagining based on balancing and walking. 4 different audios for each week were assigned, such that it included daily life experience of walking and balancing. After listening to the audio, the patient was instructed to explain in detail what he listened in the audio and what he was asked to imagine in the tape. The taped audio consists of muscle relaxation and explaining task, features, and environment condition, imagining walking using a visual perspective, imagining walking using a kinesthetic perspective, refocusing of awareness on an immediate environment and body positioning. Group 2 received 15 minutes of motor imagery audio and a conventional post-stroke lower extremity rehabilitation program based on Bobart's NDT. The duration, number, and frequency of sessions were same for both the groups. After 4 weeks of intervention program using outcome measure, change in balance and gait capabilities were recorded for both the groups. Statistical analysis and results. Data analysis was performed using SPSS version 26.0. The Mann-Whitney U test was used to non-parametrically compare the change score between the groups. Wilcoxon signed rank test was used to determine within the group differences in the scores of work balance scale and Rivermed visual gait assessment. After the intervention, there was a significant improvement in scores on work balance scale and Rivermed visual gait assessment in both the groups. In group 1, that is TOCCT with motor imagery, significant change in outcome measure was seen after 4 weeks of intervention. In group 2, motor imagery only with conventional training, significant change in outcome measure was seen after 4 weeks of intervention. The table depicts Z value after Mann-Whitney U test for both work balance scale and Rivermed visual gait assessment. The P value was set as P less than equal to 0.05. As the Z value is less than minus 1.96, suggesting that the null hypothesis is rejected. Median differences within the groups for both the outcome measures. These graphs show higher median difference suggests greater improvement in that group, suggesting that group 1 has higher median difference, that is, increase from 40 to 45 than group 2 for work balance scale. And then for Rivermed visual gait assessment, the scores are inversely proportional, and higher the score means more is impairment, suggesting that the group 1, which is decreased from 43 to 39, had more improvement as compared to group 2. Discussion. After analyzing the results, significant improvement in group 1 and group 2 was seen after 4 weeks of intervention. However, group 1 was more beneficial with higher work balance score and a decrease in score of Rivermed visual gait assessment in group 2. Our study showed the structure of task-oriented circuit class training with motor imagery provides optimal motor learning in stroke survivors. Similar results in the study carried out by Verma et al. On subacute stroke patients in 2011 were seen. There, the first group was subjected to task-oriented circuit class training with motor imagery, and the second group was subjected to only conventional base rehab for 2 weeks to improve balance and gait. Better results were obtained in the first group as compared to the second. Both in work balance scale and the Rivermed visual gait assessment, there was significant difference as compared to pre-test in the elected participants. Similar result was found in the study conducted by Bongal in 2016, where stroke patients had significant improvement in work balance scores after TOCCT intervention protocol. Previous studies support that motor imagery is considered as backdoor method for promoting patients by assessing the motor system and promoting rehabilitation. Motor imagery training stimulates proprioception, thereby enhancing balance capabilities through visual and kinesthetic imagery, focusing on joint position, joint movement, and internal sensory information about physical movement. Similar to our study, Gupta in 2017 concluded significant change in gait and balance ability after 3 weeks of motor imagery intervention in stroke patients. Conclusion, both the groups showed significant improvement in terms of balance and gait abilities. Through this present study, it may be concluded that TOCCT training when combined with motor imagery is more beneficial in terms of enhanced balance and gait ability as compared to the motor imagery along with conventional based balance and gait rehab program in post-stroke patients. The limitation and recommendations will be a small size of the study, thus the result cannot be generalized to a larger population of post-stroke patients. The parameters Rivermed visual gait assessment and the work balance scale were based on clinical observation, which could be a potential source of bias. There wasn't any follow-up of the study to evaluate the duration of learned effect of the intervention. Therefore, it is recommended to conduct further studies to explore more about long-term effects of task-oriented circuit class training and motor imagery on a larger population in post-stroke patients. These are my references. Thank you so much. It is a great opportunity to present here. Thank you so much.
Yeah, thank you, Dr. Preeti Bhutani, for keeping on the time. Now we move on to the next speaker, and this is Dr. Mahesh Sansgiri, and he's going to present on multimodal pre-rehabilitation in bone sarcomas around knee joint, a feasibility study.
Good morning, everyone. Today I'll be presenting my research titled Multimodal Prehabilitation in Bone Sarcomas Around Knee Joint, a Feasibility Study, describing occupational therapy role during prehabilitation in the field of orthopedic cancer. So bone sarcoma is a common diagnosis of cancer, and the knee joint is the most commonest joint to be involved in the diagnosis. Earlier it was managed by amputation. The current standard of care is the limb salvage surgeries or endoprosthetic reconstructions. However, the surgeries has some post-operative complication in the aspects of individual functions and participation in daily life. Post-operative rehabilitation has shown positive outcomes in these areas, but when combined with the pre-operative rehabilitation or prehabilitation, the outcomes were much better. So why did we need to do this study and what literature did we review? So prehabilitation has been studied in various diagnoses, including cancers of breast, colorectal, head and neck, etc. However, no study of occupational therapy specific prehabilitation is reported, specifically in those patients who are undergoing endoprosthetic reconstruction of the knee. Clinical benefits of prehabilitation were observed but lacked evidence regarding its effectiveness. Vital role of an occupational therapist was not explored considering psychosocial and functional aspects. So this was some of the articles that I reviewed. Coming to the summary, there were two broad divisions. One was oncology and one was general orthopedics. In oncology, we have two diagnoses which was most studied with respect to prehabilitation. It was cancer of breast and colon. In general orthopedics, two conditions that were studied the most were osteoarthritis of knee and ACL injury. The outcomes that were observed were walking with respect to 6-minute walking test, anxiety, quality of life and feasibility, whereas in general orthopedic patient population, pain, muscle strength and hospital stay was given importance. Here we can see the lack of exploration of functional aspects and occupational performance. So limited evidence is present of positive effect of prehabilitation in general orthopedic conditions. Prehabilitation has been proven to improve psychological state. However, the component of functional status is under-addressed. Prehabilitation in general total knee arthroplasties have mixed response and has never been applied in total knee arthroplasties post-oncological diagnosis. So the study aimed to understand the feasibility of multimodal prehabilitation in bone sarcomas around the knee joint for functional outcomes. The objectives were to measure occupational performance using Canadian Occupational Performance Measure, to measure emotional health using Depression Anxiety Stress Scale 21 module, to measure fatigue using Multidimensional Fatigue Inventory Scale 20, to measure nutritional status by using Subjective Global Assessment. Coming to the methodology of the study. So the study was designed as a prospective feasibility in a tertiary cancer center, Mumbai, with sample size of 24, which was drawn using convenient sampling. The study is registered with Clinical Trials Registry India. So males and females, both from age group of 18 to 60 years old with primary bone sarcomas of proximal end of tibia and distal end of femur, who were planned for endoprosthetic reconstruction and were included in the study before commencement of their chemotherapy, that is called as neoadjuvant chemotherapy. And patients with metastatic disease, secondary bone sarcomas, disease progression, pathological fractures, and those with prior mental, psychiatric, and cognitive impairment that precluded their self-care were excluded from the study. This is a Gantt chart depicting the days on which the patients were assessed. So it was in congruence with their chemotherapy schedule, and patients were specially not called to our department or hospital for assessment purposes. So one day before each chemotherapy session, that is total in 4, plus the 21st day after the last chemotherapy, preoperatively the patients were assessed, and the intervention was provided by occupational therapist and nutritionist on each follow-up. What were the occupational therapy specific interventions? Coming to techniques to maintain positive emotional health, we had relaxation techniques like Jacobson's progressive relaxation, mental imagery, pacing strategies, counseling, etc. Fatigue was managed using energy conservation techniques, work simplification techniques. Occupational performance was addressed using counseling regarding the nature of work, do's and don'ts, and the adaptive procedures. And performance components were addressed using therapeutic activities. Work simulated activities and work hardening techniques along with training was given to target the job. Pain management techniques like distraction activities and relaxation exercises were given as an adjunct, and home program was provided to the patient as well as caregiver. Coming to the results, we could recruit 24 patients since this is since this is a diagnosis which is not readily available, but however 2 patients were lost to follow-up. The normality of data was assessed using Shapiro-Wilk test, and all the analysis was carried out using SPSS version 25. The level of significance was set at less than 0.05 for all statistical tests, which was done using Wilcoxon test. So here we can see we got a fairly young population with a mean age of 27. There were 17 males and 5 females. 3 main diagnoses that we encountered. First was osteogenic sarcomas, leiomyosarcomas, and chondrosarcomas. Here we can see statistically significant decrease in the components of DAS-21 scale. D here stands for depression, A stands for anxiety, and S stands for stress. The box and whisker plot is shown here to depict the normality of the data. So emotional health issues like anxiety, depression were found to be present in oncological diagnosis as well as patients who are awaiting TKR. It is known to negatively affect functions and surgical outcomes. Researchers have suggested the use of scale which separates anxiety and depression, hence justifying our use of DAS-21. Our study reinforced the effectiveness of prehabilitation in emotional health during the treatment continuum, which was similar to all of the targeted studies. Our study showed that stress was more prevalent as compared to depression and anxiety, and that the severity of symptoms were most before the initiation of first chemotherapy, which subsequently decreased. Here we can see the statistically significant decrease of the mean level of fatigue according to multidimensional fatigue inventory scale. So fatigue was known to associate more specifically with the disease-related factors and chemotherapy, known to affect negatively on functional status. Similar to emotional stress factors, it was worst at first chemotherapy and decreased subsequently. And many researchers have stressed on using non-pharmacological interventions along with National Comprehensive Cancer Network justifying our interventions. Here we can see increase in the mean of 2 components of COPM. P here stands for performance and S stands for satisfaction. So use of COPM was suggested by multiple researchers including McKenzie and Baker. It helped us to involve patient in the prehabilitation as well as rehabilitation process, identified patient preferences and facilitate client-centered treatment. These were the common goals that were identified using COPM. Subjective global assessment helped us to identify that the nutritional status of 20 patients was constant, whereas nutritional status of 1 each improved and deteriorated. So nutrition is studied as a major domain of most of the studies of prehabilitation in oncological conditions, and subjective global assessment is advised by many researchers to record the nutritional status. Improvements in functional status can be attributed to maintenance of nutritional status too. However, more exclusive research is required. The limitations of the study was a smaller sample size, and further recommendation is the long study and with more follow-ups. So coming to the conclusion of the study highlighted about the feasibility and benefits of prehabilitation in bone sarcomas around knee joint planned for endoprosthetic reconstructions. The occupational therapy specific prehabilitation has shown improvements in occupational performance, fatigue, and emotional health of study patients. Nutritional intervention during preoperative period has shown to maintain the nutritional level of patients during the chemotherapy, and use of standardized objective measures added to the strength of the study. So what were the benefits to the patient and the profession? Rehabilitation had proven to be effective for all patients with respect to early ambulation and return to functional activities. It is a newer area in the profession and can be explored a lot. Multimodal prehabilitation can reinforce occupational therapy role with respect to standard of care. Introduction of prehabilitation in various types of cancer will strengthen the role of occupational therapy in cancer rehabilitation and create immense new opportunities. So this is example of one patient. This is her post-operative video. This is post-operative day 1 video where you can see minimal knee extension leg, which is usually not possible with standard rehabilitation in oncological total knee arthroplasties. These were some of my references. Thank you.
Yeah, thank you, Dr. Mahesh.
Thank you, sir. Thank you, ma'am.
Yes, we move on to the next speaker, Dr. Soumya Dikshit. Effect of vincristine-induced peripheral neuropathy on functional abilities of pediatric acute lymphoblastic leukemia patients.
Good morning, everyone. First of all, I would like to acknowledge and thank my guide and institution who inspired me to present this study before you all, which is titled as Effect of Vincristine-Induced Peripheral Neuropathy on Functional Abilities of Pediatric Acute Lymphoblastic Leukemia Patients. ALL is a hematological malignancy which is caused by progressive proliferation of the progenitor lymphoblasts and affects mainly bone marrow, peripheral blood, and extramedullary sites. It accounts for 40 to 50% of all childhood cancer globally and 80% of all leukemias, with overall survival rate of 90%. The first line therapy for this is chemotherapy, which is divided in 4 phases, including induction, consolidation, intensification, and maintenance. Chemotherapy comprises of various drugs, and vincristine is one of the main drugs which is given as a part of chemotherapy. So it targets mitotic spindles during cell cycles of these cancerous cells, thereby killing these cells. But it also interferes with the regulation of calcium channels across neuromuscular bundles and causes a prominent side effect of neuropathy, which presents itself as sensory motor and autonomic symptoms. But there is majorly various literature regarding these sensory motor and autonomic symptoms, but there is lack of evidence regarding long-term side effects of these symptoms on function and quality of life of these patients. There is lack of functional evaluation in previous studies. There is limited understanding of the timeline and severity of symptoms. So the objectives of our study were to find the incidence of VIPN along with its symptoms, timeline of presentation of these symptoms, and their impact on daily life roles of children, including function, play, and schooling. Long-term range objective being the determination of timeline for occupational therapy intervention. So study design was prospective observational. Setting was occupational therapy department in a tertiary cancer care center. Sample size was 55, out of which 2 patients were lost to follow-up. The study period was from October 2022 to May 2023, which included a year of recruitment and an year of follow-up. So patients with ALL diagnosis, age range between 8 to 15 years, and committed to follow-up in the center were included in the study, and patients with any pre-existing neurological deficits were or unable to complete less than 50% of follow-ups were excluded from the study. So once the study was registered in Clinical Trial Registry of India, the patient recruitment were initiated. Patient underwent a baseline before the administration of dose of vincristine, followed by 4 weekly follow-ups and 11 monthly follow-ups. So 53 patients which we recruited completed a total of 5 follow-ups, and 2 patients completed a total of 10 follow-ups. During each of these assessments, patients underwent following assessments using assessment for neuropathy using pediatric modified total neuropathy scale. Function was assessed using COPM. Balance was assessed using pediatric balance scale. Play was assessed using Takata play history, and a departmental semi-structured interview was used to assess schooling. A routine occupational therapy assessment performer was used to assess various performance components like strength, sensation, and range of motion. Coming to results and discussion, because there are various components to be covered, so have included discussion along with the results. So categorical data was presented as counts, continuous data as mean and median as appropriate. All the statistical analysis was carried out using SPSS version 25. Normality was assessed using Kolmogorov-Smirnov test. The level of significance was set as less than 0.05 for all statistical analysis. The results were analyzed for 53 patients who completed 7 months of follow-up since administration of first dose of vincristine. So the following chart depicts the incidence of the VIPN, which is 26.4%. That is 14 patients out of these 53 patients had neuropathy. 12 patients out of them had motor symptoms, 12 as well as sensory symptoms, 6 patients had autonomic symptoms, 12 patients had functional symptoms, 6 patients had balance deficits, and 11 patients each had problem in schooling and playing tasks. According to literature, globally, there is no Indian data for incidence of VIPN, but globally it varies from 12 to 78%. So the incidence of motor symptoms were 22.6%. 10 patients out of which had muscle weakness, all of whom had weakness of dorsiflexors and finger abductors. Reduced DTR was observed in all patients with motor symptoms. TA tightness and hamstring tightness were noted in 5 patients each. Reduced ankle range of motion was observed in 6 patients, and 1 patient had foot drop. Sensory symptoms accounted for 22.6%, out of which 11 patients had hypersensitivity, 1 patient had numbness, 5 patients had problem in light touch, and 2 patients had problem in pin sensibility. So globally, there is data which suggests that sensory symptoms are more common than motor symptoms in these patients, but a study by Dodeja et al. In 2019 showed similar data as compared to our study, which had similar incidence of both sensory and motor symptoms. So autonomic symptoms accounted for 11.3%, which included orthostatic hypotension and thermoregulation. The following chart depicts the change in the score of pediatric modified TNS score. A statistically significant score was noticed after 4th week of follow-up, which coincided with the study of Nama et al. 2020, which also showed similar findings. A study by Tay et al., however, shows a later significant change, which is like 8 to 12 months after the administration of first dose of vincristine. So this chart depicts the variation in the score of pediatric balance scale, and a statistically significant change was noticed after 4th week follow-up of administration of first dose of vincristine. There are no studies which were conducted to assess the balance of these patients, but there is a study by Tay et al. In 2017 which suggests are not statistically significant but a deterioration in score of TUG. So affectations in activities of daily living were noticed in 22.6% of the patients. 3 patients out of which had problem in zipping, 4 patients had problem in buttoning and unbuttoning, 12 patients had problem in stair climbing, and 11 patients had problem in walking. We also went ahead and further assessed the function using COPM, and a statistically significant deterioration in performance and satisfaction score were noticed before and after neuropathy. Incidence of play and schooling were observed to be 20.8%. There were studies which suggested use of play and schooling but there were studies that suggested use of play-based occupational therapy, but there were no studies to assess the deficits in play and schooling. So the conclusion of the study were, it is the first occupational therapy study to highlight the incidence of VIPN and its symptoms along with its impact on function, play and schooling. Limitations were, we could not record onset, progression and severity of these symptoms along a long period of time, but we could capture them for a short period of time. It is a single center study, so results may or may not be applied to other centers. Implications were valuable insights were given regarding strategic planning and timely intervention for both medical oncologists and occupational therapists. Study lays a foundation for targeted occupational therapy strategies which included prevention and management. It employs a proactive approach for enhancement of cancer treatment outcomes. It portrays a holistic approach to patient care going beyond symptom elevation to promote well-being and functionality of patients throughout their cancer treatment journey. These were my references. Thank you.
Yeah, thank you, Dr. Soumya.
Thank you, Dr. Soumya. The next speaker is Dr. Deepak Kumar Srivastava from Mumbai. His subject is experimental and analytical study on the effect of emotional literacy program on social skill development in primary grade children, 3rd and 4th standard.
Good morning, everyone. The title for my presentation is Experimental and Analytical Study on the Effect of Emotional Literacy Program on Social Skills Development in Primary Grade Children, 3rd and 4th Standard. Learning and teaching in a school have a strong social, emotional, and academic component. Students typically do not learn alone, but rather in collaboration with their teachers. Evidence from systemic review shows that school-based mental health promotion intervention, when implemented effectively, can produce long-term benefits for young people, including improved emotional and social functioning and academic achievement. Social and emotional learning in a school involve 5 key abilities: self-awareness, self-management, social awareness, relationship skill, and responsible decision-making. Social skill in a school impact safety as well as interpersonal interaction because students with the poor social skills are more likely to demonstrate aggressive or violent behavior. Some of the most important social skills for children to learn are conflict resolution, understanding, and forming positive social interaction, valuing other people and their ideas, taking turns, and taking responsibility for their own action. Development of emotional awareness leads to social skill development. Rationale of the study: if the emotional skills are developed at earlier phase in life, they may improve child social and interpersonal skills. The emotional literacy program can make the student aware about emotions and their reactions. Through these, the student's social skill may improve. Very scarce literature is available about the effect of the emotional literacy program, social skills of typically developing children. The present study evaluated the effect of emotional literacy training on social skill of primary grade children. Aims and objective of my study. Aim is to analyze the effect of emotional literacy program on social skill development of primary school children. Objective to assess the effect of the emotional literacy program on social skill development and to enhance the social skill development in primary school children. Hypothesis. My alternate hypothesis is emotional literacy program enhances social skill in primary school children. Null hypothesis. Emotional literacy program does not affect social skills in primary school children. Material and methodology, type of the study design, analytical prospective non-randomized single system study. The study was conducted in the occupational therapy department, tertiary care of public hospital and in a school in metropolitan city having Hindi and English medium classes. Duration of the study is 1 year and ethics approval was taken. Ethical consideration, study protocol, informed consent, documents and case record form were received and approved by the ethics committee, and the principal of the school and teachers were informed about the protocol of the study, and after the acceptance of their letter, we have conducted the study. Parent consent and an assent form was taken from the children, and study population, 417 children from primary grade school were included in the study. Inclusion criteria, typical developing primary school children of English and Hindi medium, and age was 8 to 10 years, and the inclusion criteria is diagnosis of children like autism spectrum, congenital, musculoskeletal, low vision and hearing. Procedure and design of the study. Primary school students from the schools in metropolitan city were included, and student was evaluated on the Tuck Family Foundation formative assessment scale, which include teacher and student survey, and baseline data was collected. The emotional literacy program was conducted in 4 sessions, 1 fortnightly. Program was full of activity and games, and each session was of 1 hour duration as follows. Session 1, which of our 1 to 2 week, students were given information about emotional intelligence, and lectures on the basic emotion was taken. Session 2, 3 to 4 week, to identify the emotion by doing activity like marking their personal emotional status on emotionometer and matching emotion by showing the pictures and situations. Session 3, 5 to 6 weeks, child has to draw a picture of his or her and of his friend and make out the differences and similarities. Session 4, 7 to 8 weeks, a traffic signal activity was included, which comprises of a 3 color. Red color means stop, yellow color means I need to think before I act, and green color means now that I have calmed down and thought I will try my best. These are the activities which is conducted during the study. At the end of the last session, participant was again evaluated on the Turk Family Foundation scale, and data was compiled and analyzed statistically. Statistical analysis was done in the SPSS software. Wilcoxon sign rank test, Mann-Whitney U test was administered, and p-value for 0.5 was set. The results and discussion. Graph 1 shows that out of 417 participants, 199 were with male from the English medium and 34 male from the Hindi medium, and 134 female from the English medium and 49 female from the Hindi medium. Graph 2 shows the mean age was 8.63 years. Graph 3 and graph 4 shows the self-control scores on teacher survey and student survey, which include that there is an improvement in the self-control after an emotional awareness program, which was supported by the study by Daniel Goldman in article in Harvard Business Review 2014. Graph 5 and graph 6 shows the persistence scores in teacher and student survey, which shows that there is increase in persistence score, and the study was, this result was supported by the Sylvia Mendeles 2014, whether emotional intelligence predict persistence. It is observed that emotional intelligence enhances persistence, retention, and overall student success. Graph 7 shows there is an improvement in the social competency on the teachers and teacher scale, and which was supported by the study by Carl et al. In 2001. Graph 8 shows there is improvement in the perception of the academic self-efficacy after a fairness program in which is supported by the Amanda Graffett et al. And the graph 9 shows there is improvement in the mastery orientation in the study in the student after the awareness program, which is supported by the Andrew et al. with high school students that there may exist a hierarchical structure to performance and mastery orientation. If the students are able to recognize their own and other people's emotion and are better able to regulate their emotions, they will have a more tools to generate a advocate behavior pattern with their peers. The present study also shows the importance of promoting emotional education, since it is one of the most useful form of a prevention against the coexisting problem. In this sense, all actions should always be aimed at creating a positive climate. For this reason, emotional education becomes an essential aspect for the focusing for the problems in his relationship and in the personal conflicts. In this way, fostering emotional education in the classroom will make a student aware of emotions they feel and why they feel them, acquiring coping skills, make responsible decisions, and fundamentally learn alternative skills to aggression and also prevent and manage conflicts. As observed in our study, students actively participated in awareness program. The students were interested and enjoying the various games and activity. The outcome measures included self-reporting, teachers and parents reporting, thus improved social competence after emotional awareness has also added up the benefit along with the emotional intelligence. The null hypothesis, emotional literacy program does not affect social skills in primary school children were rejected. Advantages of my study: more students were included in group activity, social awareness about the emotional intelligence could be established, students were happy and while participating in the awareness program and can become a community activity program to develop emotional awareness. Limitation of my study as only one investigation is involved, so more students cannot be included, and other medium students is not benefited by the study. Conclusion: existing evidence-based school interaction can improve young people's social and emotional well-being if they can be effectively adopted and integrated in school practices and sustained over time. It is being claimed that emotional awareness may lead to a development of a component of a social skills. The development of emotional intelligence become an educational goal starting from the earlier stages of children. The awareness program has led to a good social competency skills, improved interpersonal relationship as reported by the teachers. The positive results in development of various emotional components through the games, skills, and activity with the concrete affective experiences has led to a significant result in this study. Further, gradual implementation of emotional awareness program in children throughout the academic year only benefits students to develop mastery in social skills and develop competencies required for success. These are my references. Thank you.
Thank you, Dr. Deepak Kumar. The next speaker is Dr. Lalrul. Did I pronounce the name correctly? Dr. Lalrul from Bhubaneswar. And her topic is effectiveness of mindfulness practices on improving quality of sleep in the mothers of children with cerebral palsy.
Good morning, everyone. Today I will be presenting a topic, effectiveness of mindfulness practice on improving quality of sleep in the mothers of children with cerebral palsy. Introduction. Cerebral palsy is defined as a group of disorder that affects an individual's movement, posture, and balance due to injury to the developing brain. Many children with CP may have limitation in self-care functions such as feeding, bathing, dressing, grooming, ambulation, and experience communicative, sensory, and intellectual impairments. Most children with CP are cared for by the mothers, and they have to cover lots of physical activities. Therefore, they have higher risk of physical pain, and sometimes it also causes psychiatric conditions like stress, anxiety, and depression. Garib Y et al. Found that fatigue level of CP mothers are higher than those with healthy children and associated with depressions of deteriorations of quality of life in terms of physical, social, and emotional functioning. The mother of CP child reported not only declined physical and mental health, but also impaired quality of sleep as the prevalence of persistent sleep problems and need for parental nighttime attention is high among children with CP. Mindfulness. Mindfulness means paying attention in a particular way, on purpose, in the present moment, and non-judgmentally. It is also understood that mindfulness requires no religious, ethical, spiritual, or ideological commitment to practice. Mindfulness is a mind-body practice that has been found to benefit both psychological and physical health. It doesn't require any equipment to practice mindfulness. It can be practiced discreetly anywhere at any time. Rationale. Sleep quality is an important clinical construct since it is increasingly common for people to complain about poor sleep quality and its impact on daily functioning. Better sleep results in better occupational performance and improving daytime activity routines, while poor sleep can severely affect daytime performance, both socially and at work, and increases the risk of occupational and automobile accidents, poor quality of life, and poor overall health. Therefore, caregiver quality of sleep or life has become an essential component of cost or effectiveness analysis of intervention for the CP child. Heather et al. Found that there was moderate strength of evidence that mindfulness meditation intervention significantly improves sleep quality compared with non-specific active controls at post-intervention. Since it is reported that mothers of CP child have a poor sleep quality compared to a healthy child mother, and quality of sleep has a great impact on occupational performance and daily activities. Therefore, this trial is being conducted to find out the effectiveness of mindful practice on CP mothers to improve quality of sleep. Aim and objectives of the study. Aim. To study the effectiveness of mindfulness practice to improve quality of sleep in the mothers of children with cerebral palsy. Objectives. To find out changes in sleep quality, to synthesize admissible therapy for mothers of children with cerebral palsy to enhance sleep quality. Hypothesis. Alternate hypothesis. There is a significant changes in sleep quality in the mothers of children with cerebral palsy who practice mindfulness. And null hypothesis. There is no significant changes in sleep quality in the mothers of children with cerebral palsy who practice mindfulness. Methodology. Study design. It is a pre-test and post-test interventional study. Sample size, 25 mothers of cerebral palsy children were selected for the study. 5 mothers discontinued during the intervention. Therefore, final results were taken from 20 samples, 10 mothers in the experimental group and 10 mothers in control group. Inclusion criteria. Mothers whose children were diagnosed with cerebral palsy and who visited occupational therapy department for their child's therapy, mother who are the primary caretaker for their children, mother with self-reported sleep disturbance, Pittsburgh Sleep Quality Index score exceeding 5. Exclusion criteria, mothers who have a chronic illness, mothers who are pregnant, and mothers who care for another child below the age of 2. Procedure. Participants were selected according to the inclusion criteria. The purpose of the study was explained to the participants and informed consent was obtained from each of them. The participants recruited in the study were allocated in 2 groups, experimental group subject receiving mindfulness practice and control group subject receiving sleep hygiene education awareness. All the subjects in the experimental group were explained and demonstrated how to engage in mindful practice, and they were asked to practice at home at least for 15 minutes a day for 3 weeks. Every day when they come to department, they are asked if they have practiced, and we have kept the record. All the subjects in the control group were given an awareness guidelines of sleep hygiene education. Outcome measures, Pittsburgh Sleep Quality Index were used to assess at the baseline and immediately post-intervention. Mindful breathing and mindful walking. Steps for mindful breathing. Sitting in an upright, comfortable position with eye closed, relax and feel the weight of body resting on the chair. Notice and focus on sensation of the breathing and keep attention as long as possible. Steps for mindful walking. Stand straight and alert. Walk back and forth on the path barefoot. Focus on how the weight shifted or how the texture feels on the feet. Focus and draw back attention as long as possible. Data analysis. After completion of the post-treatment evaluation, results were collected and data was analyzed using IBM SPSS version 26.0. All the subjects were assessed at baseline and after 3 weeks of intervention. The pre-test and post-test data of the outcome measures for the quality of sleep were analyzed using non-parametric test statistic. The Wilcoxon sign rank test was used to determine the difference between pre and post test within the group, and the Mann-Whitney U test was used to determine the difference between the groups. Results. These are the demographic data. 10 participants in experimental group with mean age of 29.7 with standard deviations of plus minus 4.24 in the experimental group, and 10 participants in control group with mean age of 31.4 with standard deviation of plus minus 5.81. Between pre and post test score, both the experimental group and control group showed significant improvement within the group with p-value of 0.005 in both the groups, and there is median difference of 5 in the experimental group and 3.5 in the control group, where more number of median difference have better improvement. In table 3, since the p-value of 0.023 is less than 0.05, there is a statistically significant difference in post-test score between the experimental and control group in terms of sleep quality using the Pittsburgh Sleep Quality Index. Hence, alternate hypotheses are accepted. In graph 1, it is observed that the intervention received by the experimental group had more improvement when compared to the control group, with sum of rank 13.45 in the experimental group and 7.55 in the control group. Discussion. The purpose of the study was to examine the effectiveness of mindfulness practice in improving sleep quality in mothers of children with cerebral palsy. The statistical analysis results reveal that mindfulness practice are significantly effective in improving the quality of sleep in mothers of children with cerebral palsy. Mothers in both the experimental group and control group have improved, but the experimental group who have practiced mindfulness have showed more significant improvements than the control group. The results of the study attribute similar results to previous studies related to mindfulness and quality of sleep in adults by Heather et al., which suggests mindfulness have a positive effect on improving quality of sleep. In an earlier study, David S. Black also found that mindfulness practice is more effective than sleep hygiene education intervention among older adults with sleep disturbance. In our study, all the subjects had problems with sleep latency, sleep disturbance, and daytime dysfunction, and only one subject used a sleeping medication less than once a week. The subjects were also having difficulty staying mindful during the first week of the intervention due to lack of no time and disturbance, but they were able to practice as time went on. All the subjects also reported that mindful breathing is easier to practice than mindful walking. At the post-intervention test, the subjects of the experimental group reported being able to sleep better at night with less fatigue and restlessness. Hence, the results of this study suggest positive beneficial effects on mindfulness practice among mothers of cerebral palsy children. Limitations and recommendation. The limitation of the study include a small sample size. Sample collection was limited to a small geographical area, and the compliance of interventions in all the subjects could not be checked, and randomizations for improving the reliability of the study and follow-up can be incorporated into future studies to understand the long-term effectiveness of the intervention. Conclusion. The statistical analysis of the study revealed that both groups have improved after practicing mindfulness or sleep hygiene education. However, more improvement was found in the experimental group who practiced mindfulness compared to the control group. Hence, the finding of our study may conclude that the use of mindfulness practice by mothers of cerebral palsy children with poor sleep quality has beneficial effects. However, these results cannot be generalized to a larger population. These are my references. Thank you.
Thank you, Doctor. The next speaker is Dr. Vijay Batra from New Delhi, and his subject is Understanding Functional Correlates of Dynamics of Squatting during its movement transition from stand to squat in parents with early degenerative changes at knee. Dr. Vijay Batra, New Delhi. It's a non-competitive category.
Very good morning to respected chairpersons, my seniors, colleagues, my dear friends and students. Today I am going to talk about understanding functional correlates of dynamics of squatting during movement transition in patients with early degenerative changes at knee. Squat is a closed chain movement that requires the simultaneous extension pattern of ankle, knee, and hip. Squat can be performed in the various manners in terms of variations in the foot width, foot position, load position, depth. And all these variations, they influence our knee joint forces and muscle recruitment pattern. Squat actually enhances our stability if we perform it correctly. It is more effective for developing hip, knee, and ankle musculature. Apart from that, there is moderate to high quadricep, hamstring, and gastrocnemius activity in producing the squat. And the activity that we call, that muscle activity increases with flexion of knee and decreases with extension. With the onset of degenerative changes, the ability to transmit the load during movement transition from stand to squat gets altered, Henceforth, the study was conducted to understand functional correlates of dynamics of squatting during movement transition from stand to squat in normal as well as patients with early degenerative changes at knee. These were the aims and objectives to understand the dynamic of squatting in transition normal population and to understand the functional implications of onset of degenerative changes on knee on plantar weight distribution pattern and dynamic correlates of gait, that is base of support and toe out angle. It was a cross-section observation study conducted in two parts. Part 1, the 92 subjects, and part 2 from normal population, and part 2, the 80 subjects with early degenerative changes at knee was included. And the ethical approval was taken from Human Institutional Ethical Committee. The instrument used were the foot plate, dividing the foot into the 7 compartments, forefoot, midfoot, and hindfoot. And the dynamic correlate was assessed using foot impression test. In the first part, 250 participants were screened of age group 40 to 60 years to include 92 subjects from normal population. And part 2, 134 subjects with early degenerative changes were screened to include 80 subjects using inverse sampling method. So all these subjects were assessed for the plantar weight percentage, load distribution, the different compartment of the foot with greater toe in the first row and lateral 3 toes, anterior and the posterior half of medial arch, anterior and the posterior half of lateral border and the heel region. Yeah, this is how we conducted study. Both descriptive and inferential and statistical analysis was done for within group analysis for respective group for normal population during stand to squat, movement transition stand to squat was done. Also for early degenerative changes for stand to squat was done using PRT test, and for between group analysis means normal versus degenerative changes knee was done using independent T test with the at 95% CI interval with power of test as a 90 was considered significant. It was observed that within normal population during movement transition from stand to squat, the P value was found to be significant for the load distribution for most of the compartment except for the anterior half of the lateral border. Also for the dynamic components of the gait parameters were also significant. Similarly, for early degenerative changes at the knee, P was found to be significant for midfoot region especially, that is the medial arch and the heel region, and also for the dynamic correlates of gait. On between group analysis, the P value found to be significant only in the midfoot region, anterior posterior half of the medial arch especially, and the heel region during both stand and squat. After analysis, the significant differences were observed for test position, stand and squat for load distribution and dynamic correlates. During movement transition, it was observed that maximum was load in the heel region. The movement transition was there from the stand to squat. In this process, load was shifting anteriorly and with a compensatory pattern of increase in toe out angle and increase in extensor torque as well as activation of the flexor and the adductor group of muscles. After acquiring squatting, the load was shifted posterior medially with increase in flexor torque and activation of the extensor group. And the patient has position adjustment response in terms of increased toe out angle and base of support. With the onset of degenerative changes, in this patient, again it was observed the maximal load was in the heel region. But during the load movement transition, load was shifting either anterior medially or anterior laterally with the increase in adductor torque and demand on the muscle activation of the hip abductors. But once the squatting position was acquired, there was again the attempt to shift the load posterior medially, but this was done again by increasing the base of support and toe out angle. But once the disease process progresses, there was increased activation of the hip adductors and once resulting in adductor muscle bias and increasing the varus stress. Thereby, the patient, once the abductor mechanism gives away, the patient compensates by decreasing Throughout angle now, increase in base of support and waddling gait pattern. Here is showing the load distribution pattern for normal population is from posterior medial. Then for the arthritic population, it was going anterior, lateral and anterior medial region. So significant differences were observed for normal as well as arthritic population, and early degenerative changes, they experienced more impact on the ground in comparison to the normal population. So increased change in the percentage load in the midfoot region, especially in the medial arch, was found observed in the normal population. And there was maximal load in the lateral border of the foot, heel region, greater toe and second toe, and the lateral 3 region of the forefoot. On between group analysis, with the degenerative changes, it was observed the load distribution decreased significantly, especially in the heel region, lateral 3 toes and lateral border of the foot. And the patient attempted to offset the load either by decreased throughout angle or increasing with the compensatory position adjustment responses, and there was weakening of the vastus medialis and the abductor muscle group observed primarily and the piriformis muscle secondarily. Hence, it can be concluded that with the onset of degenerative changes at the knee, the squatting mechanism gets altered and the patient develops the compensatory strategies as demonstrated by change in dynamic correlates of gait deviation and plantar weight distribution. Thank you. The list of my references. Thank you.
Thank you, Dr. Batra. The next speaker is Dr. Shilpa Naik, and her subject is effectiveness of adapted multimodal sensory stimulation on comatose patients post-traumatic brain injury, a quasi-experimental study, and it's a non-competitive presentation. Dr. Shilpa Naik. Dr. Shilpa Naik. Yes, it is a competitive one.
Good morning, everyone. Topic of my presentation is effectiveness of adapted multimodal sensory stimulation on comatose patients post-traumatic brain injury, a quasi-experimental study. Introduction. Traumatic brain injury, TBI, defined as brain damage caused by externally inflicted trauma to the head, may result in significant impairment of an individual's functioning, that is physical, cognitive, and psychological behavior. Nearly 1.5 to 2 million people are injured and 1 million die every year. Depending on the severity of injury, traumatic brain injury can have a lasting impact on quality of life for survivors of all ages. One of the main and initial consequences of severe head injury is coma, along with other disorders of consciousness. Theory of sensory deprivation and neuroplasticity play an important role in the activation of reticular activating system and growth of synapses and synaptic connectivity respectively. Most benefit from the stimulation may occur when the patient is closest to the time of injury, hence time elapsed since injury is an important factor in coma recovery. An early involvement of intense, individually adapted and meaningful stimulation given by the occupational therapist would help to establish a greater continuity in care throughout the recovery. Need of the study. Although there are numerous studies published on the effectiveness of sensory stimulation on comatose patients with post-TBI in the Western context, but remains undefined in Indian context, no or limited literature is published in the field of occupational therapy, specifically in India. Therefore, it is of interest to examine the effectiveness of multimodal sensory stimulation intervention on comatose patients post-TBI to understand the effect of an early involvement of an individualized meaningful stimulation given by an occupational therapist. This will further help to define the role of occupational therapist in coma stimulation in acute care and in various policies. The aim of the study is to evaluate the effectiveness of adapted multimodal sensory stimulation intervention on comatose patients post-TBI. Objective of the study is to compare the scores of patients in coma post-TBI receiving EMS and the patients not receiving EMS to find out the improvements in scores of GCS, CRSR, and DRS in patients in coma, post-traumatic brain injury, receiving AIMS, and patients not receiving AIMS. The null hypothesis is the adapted multimodal sensory stimulation, AIMS, on comatose patients post-TBI is not effective as compared to the treatment as usual. The alternative hypothesis is the adapted multimodal sensory stimulation on comatose patients post-TBI is effective as compared to the treatment as usual. The study design was a Kochi experimental quantitative study design which was conducted at a tertiary government hospital for the duration of 1 year, and the recruitment was done by the non-probability purposive sampling method. The confidentiality was maintained and the ethical approval was taken. Total sample size was 30 participants with coma post-TBI. The inclusion criteria involved patients in coma for at least 48 hours, patients with severe head injury with GCS less than 8, patients with normal intracranial pressure, and patients above 18 years of age, and relatives with consent. The study excluded patients with cardiopulmonary instability, patients with mechanical ventilation, patients having severe infections, and patients in coma due to other causes than trauma, and patients below 18 years of age. Initially, the study assessed 86 patients for the eligibility, out of which 56 were excluded for various reasons, and 30 patients were recruited finally, which were divided into two groups, that is experimental group A and control group B. 15 patients were allocated in each group. The total number of follow-up was 15 in each group, and the total number of patients analyzed were 15 in each group. There was no loss to follow-up reported in both the groups. The experimental group A included AIMS, that is block 1 and block 2, plus the treatment as usual, whereas the control group B was given only the treatment as usual. The block 1 and block 2 consisted of various stimulations like orofacial stimulation, acoustic, visual stimulation, olfactory, taste, tactile stimulation, proprioceptive and kinesthetic, thermic stimulation. Every stimulation was followed by a 10 minutes of break, and every block was preceded by a baseline of 10 minutes and finished with a baseline of 10 minutes. The total duration of intervention was 2 hours with intermittent breaks of 10 minutes for every patient for every day, and frequency of intervention was 7 days per week for 2 weeks. The total number of sessions for each patient were 14 sessions. Special precautions were taken for frequency and intensity of the sensory stimulation given. Low noise level and adequate intervals were maintained. There was no static pattern for every patient, but it's based on the actual functional level achieved for the diverse section. There were total 3 outcome measures used: Glasgow Coma Scale, Coma Recovery Scale Revised, Disability Rating Scale, and a derived verbal score was used to predict the verbal score of GCS for the patients with tracheostomy. Data analysis: paired t-test was used to compare the data within the group. Unpaired t-test was used to compare the data between the groups by using the SPSS version 23. An alpha level of 5% was set to measure the significance. Results: demographic data. Total 30 patients were involved, out of which 22 were male and 8 were females. The mean age was 43, and in the intervention group it was 41, and in the control group it was 45. Comparison within the experimental group, as shown by in the graph. There was a significant improvement within the experimental group, the blue bar representing the post-test results. However, in the disability rating scale, it is lower than the pre-test, indicating a positive effect. The p-value in all the outcome measures were less than 0.5, indicating a statistically significant improvement. Comparison within the control group. In the control group, there was a significant improvement in the post-test, the blue bars representing the post-test results. The p-value was less than 0.05 for all the outcome measures in the control group. Comparison between the group: although both the groups showed a significant improvement post-test within the group, on comparison between the groups, the experimental group showed a significantly higher and faster improvement in all the 3 scales as compared to the control group. The p-value showing less than 0.05 significance in the post-test. Discussion: the purpose of this study was to evaluate the effectiveness of adapted multimodal sensory stimulation in comatose patients post-TBI. The results suggest that the implementation of adapted multimodal sensory stimulation therapy can enhance consciousness recovery in comatose patients post-TBI. The study found that there was a statistically significant improvement in both experimental and control group. On comparison between the groups, improvement shown in the experimental group was more than that of the control group. The results of this study confirms the observations in the previous results that 8 out of 16 patients who had received daily multisensory stimulation and sensory movements of the limb completely recovered from a deep coma. The remaining 8 patients also eventually recovered. Similarly, it was previously observed that the sensory stimulation implemented at an early stage of coma is beneficial to the brain-injured patient. It was noticed that a directed, person-related stimulation with individual meaning stimuli seem to evoke more significant reaction than the undirected stimulation. Correspondingly, the importance of sensory regulation was observed, which consists of a regulation of background noise levels and introduces intermittent breaks between the therapy session. Rationale is that exposure to frequent and various sensory stimulation of sufficient frequency, intensity and duration facilitates both dendritic growth, synaptic connectivity and neural plasticity in those with damaged nervous system. Limitations, this was a Kochi experimental study without randomization with a methodological limitation. A small sample size, duration of the study was short. Studies with a larger sample size using a randomized clinical trial and a larger period of follow-up is recommended in future studies. Study implications. This protocol can be used as a part of occupational therapy practice in early intervention in patients with coma post-TBI. The statistical analysis of this study findings can be used to conduct a randomized control trial in the future studies. Conclusion, the present results conclude that adapted multimodal sensory stimulation has significant effect on the GCS, CRSR and DRS when compared to the results of control group. It also indicates that stimulation treatment should always begin in the acute stage, should be more structured in terms of frequency, intensity and adequate intervals. It should be meaningful and concentrate on the individual patient rather than following a static pattern. These are my references. I would like to thank all the participants and the families of my intervention, the dean of my college and my guide. Thank you.
Thank you, Dr. Shilpa.
I request all the presenters to be on the stage for question answer session, post which our chairman will wind up the session.
So as we move on to the question answer session, so the audience is encouraged to have direct questions and the questions be very specific, 2 questions per speaker, and the order of the questions will be as per the order of the presentation. So questions are invited for the first speaker, Dr. Preeti Bhutani.
Good morning. Myself, Dr. Meenakshi Batra. I have a question. Preeti, you mentioned in your motor imagery audio, you did provide the relaxation. How did you do that?
Hello. Thank you for the question, ma'am. The motor imagery audio was actually adapted from one of the websites for which I did a certification course for the same, and the audio was based on patients' local language only, so that they can understand, and in order to do that, they can understand and conflict with and go with that. So it was based on that only. The relaxation component was like they have to relax for a certain time, deep breathing exercises was there, and for certain minutes only, because the whole audio was comprised for 15 minutes only. And for the same, to implement that, I actually went under a course or certification course for the same, so that the authenticity of the audio and the compliance to motor imagery will be maintained.
All right. Thank you.
Thank you, ma'am.
Any more questions? Okay, if not, I had a question. In your presentation, you mentioned you had a slide on the bar charts, okay, and there you have just written that certain group, the scores are high. Did you try to analyze them and see whether they are significantly high?
Yes, sir. Wilcoxon-Sang rank test was done within the groups. So the p-value was less than 0.001. and the significance level was set as 0.005, less than 0.005. So there was significant result in both the groups, but the first group showed significantly more beneficial than the second group. And to compare both the groups non-parametrically, Man-Whitney was used for the same.
It was there on the slide?
Yes, sir.
Okay,
Yes.
I think so. I'm sorry, I missed that out.
Yes.
Thank you.
Thank you, sir.
We move on to the next speaker, Dr. Mahesh Sansgiri. Yes, questions are invited for that presentation. He had presented on multimodal prehabilitation in bone sarcomas around knee joint, a feasibility study.
Good morning, myself Dr. Meenakshi Batra. I just wanted to know what is the outcome of your study in a nutshell? Outcome. What is the outcome of your study?
So, thank you for the question, ma'am. The basic outcome that we studied was the feasibility, whether this prehabilitation, the multimodal prehabilitation, keeping occupational therapy specific intervention in mind, whether it was feasible or not, considering the diagnosis, and what was the effect of multimodal prehabilitation on different outcome factors such as mental health, fatigue. So it showed positive outcomes on all the aspects, considering mental health, fatigue, and the occupational performance, which was assessed using COPM also.
Thank you.
Thank you, ma'am.
Any more questions for him? If not, I do have a question. You had mentioned about work hardening. You had employed work hardening. But at no point you have mentioned what kind of work are you targeting. Because work hardening is very specific to work. But there was no mention of what is the nature of work that you found out in the list of subjects.
Thank you for the question, sir. Basically, there was diverse occupations which we targeted. Some of them were lab assistants, some of them were laborers. We didn't target the laborers, keeping in mind the chemotherapy schedule and the disease-related factors, but more of office-related works, sitting tasks, or lab assistant standing tasks. All the basic tasks were targeted for work hardening, not advanced tasks, because it could lead to
Maybe you could have listed
Yes, sir.
them up in your presentation.
Yes, I'll
Okay.
definitely keep
Thank
it in
you.
my mind. Thank you, sir. Thank you for that.
We move on to the next speaker, and that is Dr. Soumya Dikshit. And she had presented on effect of vincristine-induced peripheral neuropathy on functional abilities of pediatric acute lymphoblastic leukemia patients. Questions for Dr. Soumya Dikshit?
Good morning, Soumya. I just had a question. You mentioned incidence of VIPN, right? Incidence is representative in a larger sample size. So, did you mention in your study?
Ma'am, incidence is defined as when you follow up a patient or you recruit a patient for a period of time, specific period of time, and that period of time, how much amount of patients you get. So in a year of recruitment, we got 55 patients. So that's why I mentioned incidence.
That was with respect to your study only, right?
Yes.
Not representation of the sample.
No.
Thank you.
Yes.
Any more questions for her? Okay, if not, then we move on to the next speaker. Next speaker was Dr. Deepak Kumar Srivastav, and he had presented on experimental and analytical study on the effect of emotional literacy program on social skill development in primary grade children, 3rd and 4th standard.
Good morning, Deepak. I just had one question. You mentioned emotional literacy program, right? Who executed that in the school?
Thank you for the question, ma'am. Ma'am, it was executed by me. We have designed the program based on the 6 second models of emotional intelligence, and we have designed the activities according to them. Means we have designed our protocols according to the 6-second model of emotional intelligence.
All right, thank you.
And any reason you chose 3rd and 4th standard student?
Yes, sir. Thank you for the question. Sir, students means for 3rd and 4th standard, this is the stage where from which we will include them to develop the various, means they are more interested in playing games and all. And these are the students which means they have a jealousy of their peers and all. So we included that, thinking of that from this early stage only we can start mentioning about the emotional, so that they will be benefited in further their life, and various studies have supported to this.
Okay, yeah, thank you.
Thank you, sir.
Our next speaker, Dr. H. Lalru Atfeli. I'm sorry, did I pronounce correctly?
Lalru Atfeli.
And she presented on effectiveness of mindfulness practices on improving quality of sleep in the mothers of children with cerebral palsy. Yes, questions? Yeah.
Hello, good morning. I am Dr. Kamal from New Delhi. I just would like to know how to differentiate mindfulness versus meditation, and how it is, what is the implication of these techniques in occupational therapy?
Sir, mindfulness is like how much aware we are in whatever we are doing, whatever we are doing, how much aware we are. And then meditation is like the concentrations and the focus.
Okay. Okay,
Thank you.
we move on to the next, I think so there's a question from there.
Yeah, hi Feli. I'm Dr. Firdaus from New Delhi. My question is, why did you select the same scale for screening and outcome measure? Though because I was going through, there is one more scale through the same owner.
Okay, I am using the same scale because Pittsburgh Sleep Quality Index, it is reliable and validated for screening tools and outcome measures for measuring the sleep quality. That's why I'm using both for my screening tools and outcome measure.
Okay, thank you.
Yeah, thank you. I mean, there is an interesting observation. We, since yesterday, I have been hearing several presentations, and our presenters have been using scales which emerged out of Pittsburgh University, and we do have one of the faculty from Pittsburgh University right here, so it's quite an interesting fact. Yeah, we move on to the next speaker, Dr. Vijay Batra. That was a non-competitive paper, and he presented on understanding functional correlates of dynamics of squatting during its movement transition from stand to squat in patients with early degenerative changes at knee. Yes, questions for Dr. Vijay. Yes, no questions? So let me have the privilege of asking one question. Yeah, so did you try to age match both the groups?
Sir, age matching was practically not possible. In my study, I included the age range 40 to 60 years with the onset of degenerative changes. And
what is the mean age, both the groups?
Mean age was approximately 51.6 years. And out of this, 57 were female, and with the in the part 1, 57 female, and then the male. and the part 2 was 55 females. So it was observed that we were more concerned on the inclusion criteria. In the part 1, the normal population, either the subjects have back pain, neck pain, or history of knee pain, they were all excluded from the study, the part 1. The part 2, and moreover, only the subjects who gave their consent, inverse sampling method was applied. The part 2, again, the importance was, rather than matching the age, was given to the involvement, severity, grade 1 and 2 on the Lawrence and the Kelvin scale.
Fine, yeah, thank you.
Thank you, sir.
And, yeah, thank you. And the last speaker, Dr. Shilpa Nayak, and she had presented on effectiveness of adapted multimodal sensory stimulation on comatose patients, post-traumatic brain injury, a quasi-experimental study. Yes.
Good morning, Shilpa. You explained the multimodal intervention, multimodal stimulation, right? So can you explain the type of modalities that you selected and the type of stimulus?
Good morning, ma'am. Thank you for your question. The types of stimulations I have used for the acoustic stimulation are like different types of videos that a patient was familiar with or used to watch earlier, or his favorite music, And the type of, for the visual stimulation, I have used a mirror and different types of videos that a patient was familiar with. For gustatory and nasal, I have used different types of stimulus and different types of taste that the patient used to like earlier or was familiar with. And others I have used mainly the whatever stimulus has to you give, and the patient used to respond to the most, those stimulus were given regularly to the patient.
All right, no motor stimulation, proprioceptive, nothing.
Ma'am, kinesthetic and proprioceptive stimulations were given, like different movements. Each movement, for example, flexion of the upper limb for 2 seconds, maintained and then released, and then consequently like other joints.
All right, thank you.
Yes.
Hi, Dr. Firdaus again. My question is, you mentioned comma, right?
Yes.
But as we go through GCS, there are various scorings because in my clinical practice, I have worked with such patients. So just wanted to know to which patient exactly your study is reliable, whether it was for vegetative or for minimally conscious patients. Because for comma, we require several weeks of unconsciousness.
Yes, doctor, as I've mentioned in the inclusion criteria, the severe head injury patients with the GCS less than 8 or equal to 8 were selected in my studies.
Okay.
Yep.
All right, thank you.
We'll stop at that. Yeah. Thank you.
Thank you.
So with that, we come to the end of this question answer session for this scientific session 7. And are we going to sum it up before?
Yes,
or the certificate
briefly sum
yes,
it up.
Yes.
Yeah.
So congratulations to all the presenters for your wonderful presentation, and your presentations were well crafted for the theme that was kept for this session, and that is gardening for new innovations. Just a quick observation for the younger presenters. You had mentioned for all your studies, one of the standard thing that you mentioned that as part of the limitation, you had a small sample size, but actually you all met the sample size criteria which you had laid down for your studies. So as long as you meet that, small sample size cannot be limitations, because that sample size was decided with a statistical method. So it will be a limitation only when you fall short of that decided sample size, right? So just a quick piece of observation. So we had wonderful presentations, well chosen topics, okay, and I sincerely hope that you are going to carry forward these endeavors into your further professional practice. Thank you all.
Ma'am, you want to say some few words?
I must congratulate all of you. You had a very good, but I have just one, I don't know, I would say advice or whatever. I felt everything was statistically excellent, no doubt about that. But I wish and I hope that in future, most of the presenters would show something about what, as therapy, in occupational therapy, you are doing, the actual activities. I didn't see, not only with you, this is for all the other presenters so far. I did not see them. I think as occupational therapists, we are not becoming just statisticians. No. We have to show what we are doing in therapy. I think we should pay attention to that next time. Thank you.
Thank you. I request both the chairs to please hand over the certificate of presentation to all the authors. Dr. Preeti Bhutani. Soumya Dikshit. Deepak Kumar Srivastav. H. Lal Ruatfali. Dr. Vijay Batra, sir. And Dr. Shilpa Naik. Now I call upon my scientific committee members, Nivedita, Namita ma'am and Shivani to please felicitate the chairperson for the last scientific session for all the member delegates. Shovan Saswar.